Well, good morning, everybody. My name is Jay Africa. I am the Behavioral Health Director in the County of Marin and a proud NAMI California board member. I'm really pleased to be in the space with Angela Kimball. Angela Kimball is the Director of Advocacy and Public Policy in NAMI National. Angela brings expertise in grassroots advocacy campaigns and mental health policy to NAMI, as well as a drive to fight. I know, sorry, California National, as well as her drive to fight inequities and a champion to better care for people with mental health conditions as well as their families. Previously, Angela led NAMI's advocacy and policy team, and in a prior role, worked on quality integration of Medicaid health, mental health, substance use, and dental services as an innovator agent with the Oregon Health Authority. Wow. For several years, Angela served as NAMI's Director of State Advocacy. There's a multiple awardee recipient for her work in legislation, specifically on children's mental health reform and mental health parity. You are a force to be reckoned with, Angela. And Angela graduated from Linfield College in McMinnville, Oregon. So it's a pleasure to be here with you, and I'm going to turn it over to you, Angela.
All right, thank you so much for that kind introduction. So now I am going to share my screen and hopefully everybody can see my slides here. And I want to thank you for joining us today. We're going to share an overview of what is actually happening in the nation's capital and focusing really on why it matters for mental health. So let me see if I can get these slides to move. Okay, so you're all aware that what your state and counties invest in and that the laws that they pass affect the mental health services and supports you see. But Congress and the White House and the federal agencies of the White House also play a critical role in infusing communities with funding and with shaping service delivery through policies. And that's why NAMI at the national level advocates with Congress and the administration. And we partner with many colleague organizations to increase funding and promote better laws and regulations. I'm going to start by mentioning NAMI's federal legislative agenda, which covers a wide range of issue areas. As I'm sure you're all very aware of, mental health touches so much of our lives. And so our legislative advocacy touches on a large number of issues. I'm not going to read all of these, but I will note that our priorities range from advancing mental health research to ensuring safe and affordable housing, to expanding 988 crisis response and diverting from justice involvement. So earlier this year, I wanted to let you know that in March, we scored some important wins for mental health in the American Rescue Plan. And you all helped. Over 100,000 emails went out from advocates across the country, and that helped influence members of Congress. And I'd like to mention that what was in that our plan was $1.5 billion for the mental health block grant, and 85% FMAP state option for mobile crisis teams. And what 85% FMAP means is that if a state chooses this state option for their Medicaid program, for every 15 cents the state spends on mobile crisis teams, the federal government will chip in 85 cents. So a high FMAP rate, like 85%, is basically a bargain basement price for buying services that are going to help people in your community. The American Rescue Plan also included $100 million in behavioral health workforce training, billions in emergency rental assistance and other housing programs. And I apologize for this and for looking over, but I feel like my slides have a mind of their own and advance without me seemingly doing anything. So I'll also mention that there was significant funding to expand pediatric mental health access. And collectively, this represented the single largest investment by Congress in mental health ever. So what's happening today in Congress? Well, you may have been hearing in the news many of these things. So first, it's helpful to note that the federal government runs on a federal fiscal year that actually began on October 1st and has been common in recent years. Congress did not reach a budget agreement for fiscal year 2022. Instead, they passed a continuing resolution that's going to expire on December 3rd. And at that point, Congress is going to have to either pass a budget for fiscal year 2022 or extend the continuing resolution even longer. And the challenge with continuing resolutions are that they keep most funding flat, and they typically don't allow for meeting unanticipated expenses or increases in demand. They also mean that when Congress finally passes a budget, there's actually less time to spend the money. And that is not helpful to states and communities that are trying to plan and implement services. I would like to note that this year, there were some anomalies or special increases included in the continuing resolution. And mainly, these were for disaster relief. But one increase that was included was for the National Suicide Prevention Lifeline, which is gearing up for increased demand when 988 goes live as a nationwide 3-digit crisis line number that routes through the lifeline. So there are a few other things that Congress and the administration are grappling with. As many of you know, they temporarily lifted the nation's debt limit, but like the CR, they're going to have to revisit this by December 3rd. And they're also trying to pass a bipartisan $1.2 trillion infrastructure package. So think roads, ports, bridges, and broadband. And at the same time, they're trying to pass a highly partisan Build Back Better plan. Some people refer to it as human infrastructure that makes investment in administration priorities using a process known as budget reconciliation. That process has special rules that make it very complicated, but also allow for a simple majority to pass the bill. Oops, once again, my slides keep moving. So there is a lot of debate in Congress over the size and scope, even within the Democratic Party, which controls both the House and Senate, but they do so by very slim margins. And so that means that all it takes is 1 or 2 members to be disruptive in terms of the path forward for the budget reconciliation package. I'll note that this is the year that's widely believed to be the last big opportunity to make sweeping investments by this administration, because next year's midterm elections are generally expected to change the balance of power in either the House, the Senate, or both. And even though the new Congress wouldn't be starting until 2023, in a midterm election year, like next year, it's highly unlikely that Congress will be able to pass significant or controversial legislation next year. So now I'll talk about what's in the Build Back Better plan, that budget reconciliation package, that affects mental health. And to be honest, there are several NAMI priorities that are embedded in the plan as it currently exists. So we're waiting to see what washes out as Congress negotiates where they're going to go with this package. But I will mention some of the priorities that we really hope stay in. And first is the Medicaid Reentry Act. And what this would do is require states to have their Medicaid plans cover people who are Medicaid eligible 30 days before they're released from incarceration. This is a NAMI priority because it would help pay for treatment inside of jails and prisons, and very importantly, could ensure that many people have coverage on the day that they return to their communities. That's huge. also has a price tag attached to it. So this is one of the reasons it's in the budget reconciliation package, because it would change Medicaid and incur an additional cost to the federal government. Second piece that is in the Build Back Better plan that we are highlighting is something called civil monetary penalties, which is just another term for permitting the federal government to impose fines on health insurance plans that violate the federal parity law. And some of you may be thinking, wait, can't they fine health plans for violating the law already? No, they cannot. But this provision makes, if this provision makes it through, there'll finally be some potential repercussions for those plans that are subject to federal regulation. There are billions and billions of dollars in housing assistance in the Build Back Better plan, including housing choice vouchers and other programs that help people with serious mental illness who need help with housing. It includes coverage for low-income adults living in 12 states that have not expanded Medicaid. That doesn't include California. You already have Medicaid expansion, so not a benefit for all of you, but it definitely helps people with mental illness across the country, because in those 12 states, if you are a single adult with mental illness, it doesn't matter how severe your symptoms are or how poor you are not eligible for Medicaid in those states unless you meet federal disability criteria. And that is a challenge that is very difficult for a lot of people to meet. So we're definitely hoping for expansion of Medicaid. The last thing that's in the Build Back Better plan that we're really looking at is a significant investment in home and community-based services. And I'll note that NAMI has been partnering with Mental Health America to advocate that the provisions in the home and community-based services part of the bill explicitly include peer support specialists. We know how important peer support specialists are to people, and we want to make sure they are definitely included as people expand home and community-based services. So, as you can tell, there are very significant provisions here that, if passed as part of that Build Back Better plan, would really help people with mental health conditions. I also want to note that Congress needs to find ways to pay for the Build Back Better plan. So there are provisions that generate revenue, and that is often controversial. And one provision is to allow Medicare to directly negotiate drug prices, which is a fraught issue on Capitol Hill. So many of these decisions will be based on the anticipation of next year's midterm elections and how various issues and votes could play out with voters. So stay tuned. But I'd like to leave you with a quick fact here, and that's that NAMI activists sent over 4,000 emails this month to Senate Democrats to support NAMI's priorities in the Build Back Better plan. Some of you may be wondering, why only the Senate Democrats? And the reason is really pretty simple. It's that Senate Republicans are not backing the Build Back Better plan at all and are not negotiating what should be in it. And so sending emails to them would not be viewed as helpful, either by their offices or by us. With that said, I'd like to say, if you're not receiving NAMI's alerts on federal legislation, you have a chance to sign up now. We've put the web link at the bottom of this slide, so make note of it. And also note that if you don't take action but are signed up, you may not receive alerts very often. The reason for this is that if large numbers of emailed people don't respond, servers begin to start treating our emails as spam. So as a result, we often send alerts only to people who've taken action in the last year. If you're thinking, oh no, that's me, I've signed up, but I haven't gotten around to taking action on any alerts, don't worry. Just go back to that action center, and there are some standing emails there that you can send, and then that will count as an action. Or you can share a personal story on there. This will help get you back into the active camp. so that you can receive more emails. And now back to the fiscal year 2022 budget. So I mentioned we have a continuing resolution in place without a fiscal year 2022 budget. We have Congress arguing over the infrastructure plan and the Build Back Better plan. But again, not too many weeks left before they really need to kind of do something about the budget. So I want to mention that the House has already passed many parts of the 2022 budget, and many provisions that we really, really like are in there. So I want to mention that the House 2022 budget includes nearly double the previous annual budget for the Community Mental Health Block Grant. So if passed, the budget would then be $1.58 billion for that block grant, which gets a portion to every state based on a formula. So California, being a large state, gets a fairly large hunk of that. I'll also mention that the House also doubled something called a set aside for crisis services in that mental health block grant to 10%. So what that means is that 10% of a state's mental health block grant funds would have to be spent on crisis services. And this is largely in anticipation of the rollout of 988, a 3-digit number for mental health and suicidal crises. Also in anticipation of that rollout, the budget includes $113 million for the National Suicide Prevention Lifeline, and something we were delighted to see, a brand new $100 million program to fund mobile crisis teams. So if passed, that creates a brand new program. And when you have a program in place, it becomes something that you can work on increasing in the future. Another piece that we've been advocating for that was in the House budget is a crisis services coordinating office within HHS to ensure that 988 crisis response is implemented well. This is really critical because states and other federal agencies really need help coordinating and making well-informed decisions around 988 crisis response. And then finally, I'll just touch on this. There's a new $100 billion line item for mental health professionals and services in the Department of Education budget. And I think this is in part a response to everybody's experience that during this pandemic, so many of our nation's children have really been feeling the mental health effects of the isolation, of uncertainty, of so many things that have happened in our world in the last year and a half or longer. With all this, there's even more going on. So this is a highly partisan environment that we're working in Congress. But I have to say, there are many members of Congress that are seeking areas of agreement. And one of the beautiful things about mental health and substance use is that those are conditions that both sides of the aisle are seen as highly important and that they would like to achieve some bipartisan support on. So Senator Ron Wyden, who's chair of the Senate Committee on Finance, and Senator Mike Crapo of Idaho, the ranking member, so they're of different parties, also of the Senate Finance Committee, have announced that the Senate Finance Committee will be working on a bipartisan mental health and substance use bill focused on 5 areas. Again, my slides here, I'll move back. Strengthening the workforce, integration, coordination, and access to care, including crisis care, insurance parity, telehealth, and child and youth mental health. And I'm just going to touch briefly on the child and youth mental health. So I mentioned that COVID brought this heightened awareness of children's mental health, but I want to share that about 1/3 of all parents have noted that their children's mental health is worse than before the pandemic. So we have more children needing mental health care than ever, yet fewer received any kind of treatment during this last year, except for one thing that did increase rapidly, and that's the percentage of children and youth going to emergency rooms for mental health crises. So we're grateful that the Senate Finance Committee is committed to addressing both children's mental health, but also issues like workforce development and telehealth and access to care and parity. The committee actually asked all of its 26 members for recommendations. And one of the great things that NAMI did was create state-specific template letters for NAMI state organizations to send to their senators who are on their committee with their recommendations in each of these areas. And one of the things that the committee made clear is that they needed to work within what is called their area of jurisdiction. So the Senate Finance Committee isn't in charge of the universe of all things mental health. They are in charge of a certain set of kinds of issues. Fortunately, Medicare and Medicaid and insurance plans are within their purview. So we articulated issues that were within their jurisdiction in those template letters. And we will be working with another committee, the Senate Help Committee, who has purview over other areas like workforce development. So in many of our states who reached out, they got responses back and got meetings with those Senate offices. And so senators who are on that finance committee are hearing our recommendations, knowing what pieces of legislation that are already out there we would like to see advanced and rolled into a bipartisan package. So that's actually very exciting to hear. There's just a lot of movement for mental health care on Capitol Hill. And with that, I'm going to move into talking about the administration. So with all that happens in Congress, it's really easy to forget that a lot happens behind the scenes in federal agencies. Federal agencies actually interpret Congress's laws through regulations. They issue guidance and requirements for programs. They're the ones who send out the money. So they actually have a lot of impact on what happens in mental health. And one of the most important agencies to NAMI is HHS, or Health or Human Services. I just want to point out that HHS houses Medicare, the federal health insurance program for older adults and adults with disabilities, Medicaid, which is a joint state federal health coverage program for low-income people, the National Institutes of Mental Health, the CDC, SAMHSA, as well as several other agencies, all bundled under HHS. So suffice it to say, HHS is huge, and the secretary of HHS, Javier Becerra from your great state, has a huge role and extraordinarily pressing issues. And that's why NAMI was really impressed that Secretary Becerra held a small roundtable of just 10 organizations to speak to him about the health and mental health of children as they began returning to school. So NAMI's CEO, Dan Gillison, was able to use that opportunity to press for some of NAMI's priorities to advance school mental health and the children's mental health workforce. He was also invited to participate in another very important meeting with Administrator Chiquita Brooks-LaSure, who heads up the Centers for Medicare and Medicaid Services. And again, NAMI had the opportunity to outline key issues in Medicare and Medicaid. And here's some of the issues that we've been impressing upon the administration. First, we've been emphasizing the discriminatory nature of Medicare's coverage. Medicare does cover mental health care, but it covers just very limited types of providers. For example, peer support specialists and marriage and family therapists and licensed professional counselors cannot bill Medicare. It has limited provider networks, limits the types of covered mental health services, and it has a lifetime limit on psychiatric inpatient care and surveys everyone who has an inpatient stay except people with a primary diagnosis of a mental health or substance use disorder. And the reason why is they never bothered to test the survey tool on people with mental health and substance use diagnoses. And we think this really reflects an inherent bias against people with those diagnoses. We've made our objections known, and better yet, so have you. So I'll let you know this. Earlier this year, over 600 NAMI advocates shared really personal stories in comments to Medicare around this very issue. And I have to tell you, Medicare listened. That was a lot of comments to get on an obscure, federal proposed rule. And so they have been bringing us in to have discussions. This is going to be a slow moving process. It takes about a couple of years to get any traction in terms of something like a patient experience of care survey, but the conversations have been very rewarding, and we're hoping that we have good news for you in a year or two. We've also, let me go back here. So we've also been touching on exclusions in Medicaid coverage for certain inpatient facilities and for inmates. So I mentioned the Medicaid Reentry Act that's before Congress, but we're also talking to CMS, Centers for Medicare and Medicaid Services, about making it easier for states to waive these exclusions. We also want more guidance from Medicaid about how state Medicaid programs can cover crisis services and services in schools and people in jails and prisons. And finally, we've been really emphasizing the need to expand the mental health workforce, the role of HHS programs in really creating incentives and removing barriers to a behavioral health workforce. And lastly, we've been noting that there are over 160 vacant positions at SAMHSA. Our states and communities rely on SAMHSA grant funds, and frankly, they don't have the people to get the work done. So we have emphasized that those positions need to be filled and filled fast. So we'll stop there and say that I've mentioned 988 in crisis response a few times, but many people aren't aware of it. So I wanted to spend a little bit of time talking about NAMI's top policy priority. Over the last couple of years, NAMI worked alongside colleague organizations like the American Foundation for Suicide Prevention and the Trevor Project to help establish 988 as a 3-digit number for suicide prevention and mental health crises. It's going to be run, as I mentioned before, through the National Suicide Prevention Lifeline, and it's going to go live by July 16th of next year. Some cell phone carriers are already routing 988 calls to the Lifeline, but we're still advising people to use 1-800-273-TALK at this point because not all carriers are transferring calls. But with that, what I want to say is this. NAMI views 988 as really offering the promise of a reimagined response to people in crisis. But this is only going to happen if states like California act to create a 988 crisis response system. And look at these headlines. This is the reason why. Today, law enforcement is often called to respond to people experiencing a mental health or substance use crisis. And so unlike other healthcare crises like heart attacks, mental health crises are often criminalized or worse. And over the last 5 years, about 1 in 4 fatal shootings by police were of people with mental illness, and 1 in 3 of those were people of color. So think about it. That's tragic. And then furthermore, millions of people seeking crisis care have ended up in hospital emergency rooms. Sorry again for the slide advancement. In emergency rooms that don't have the capacity to provide psychiatric treatment. And it doesn't have to be that way. So now I'll share a little bit about our vision for crisis care that we'd like to see across the country. there's a ghost in my computer that's advancing slides. I really can't explain it. Apologies. But in terms of our vision here, it's really made up of 3 components. And the first one is simple. It's someone to talk to. 24/7 lifeline call centers with well-trained staff that can effectively respond to a range of mental health, substance use, and suicidal crises, that's available by text and chat and able to dispatch mobile crisis teams. This is happening in some states, and it should happen in California. And the second component of a 988 crisis system is someone to respond. In about an average about 2 in 10 calls to a crisis line, there's going to need to be a direct response. And mobile crisis teams are teams made up of staff who are really skilled at de-escalation, at engagement, and connecting people to services and supports. There's a lot of different models of mobile crisis teams, but they typically share one thing in common. They meet people where they're at, and they provide an alternative to a law enforcement response. Now, some people are going to need further support, and that brings us to the third component, which is someplace to go. About 3 in 10 people are going to need crisis stabilization. And what we're really looking for are crisis stabilization programs that provide an alternative to an ill-equipped emergency room. And often our preference is these are in living room-like settings, often in an open environment, recliners, and that provide observation and stabilization and connect people sometimes to more intensive services and sometimes to community-based care. And in the best versions of this, very much a recovery focus and a use of a lot of peer supports, and really a recognition that people present with mental health, with substance use, with suicidal ideation, and that these are places that are equipped to handle all the issues a person might present with. And here's just a different version, a different way to visualize this crisis response system. So we're thinking of a crisis line where about 80% of all calls are really resolved over the phone, because you've got hopefully expert trained staff who are able to connect people or help them resolve their issues right there. Mobile crisis teams. And you'll notice that there's a police car underneath that. And the reason there is the idea is that police, instead of responding to somebody who is experiencing a psychiatric crisis, can call a mobile crisis team instead of responding themselves. So they have that alternative that they can tap into. And similarly, with crisis facilities, that law enforcement can, if they happen to pick somebody up and they believe they're experiencing a psychiatric crisis, go straight to the facility and be able to do a warm handoff that gets somebody into treatment and gets the help and respect and dignity that they deserve, rather than a trip to a jail. This slide also mentions post-crisis wraparound, which is an important component. And just to let you know that in places that have implemented this kind of response model, like Arizona, they have actually achieved lower rates of arrest, lower uses of emergency departments, and reduced inpatient hospitalization, which is a great thing. So with all that, what I'll mention though is the reality, and that is that crisis call centers are typically underfunded. The National Lifeline gets federal money to coordinate, to train, and to route calls to local call centers and to provide a backup system. But local Lifeline call centers rely primarily on state and local funding, and that's often inadequate. So we're expecting a spike in demand once people become aware of 988, and it goes live for sure next year in July. And when calls that currently go to 911 hopefully are eventually diverted to 988. We want calls answered locally as much as possible, but that requires resources. I mentioned, I think previously, Georgia, for example, who has a crisis and access line that's able to book urgent appointments over the phone. They have real-time availability of all inpatient beds all across the state. They're able to dispatch mobile crisis teams. We want that kind of response everywhere. And we know that mobile crisis teams are spreading rapidly, but they're still not available everywhere yet. Some states are way ahead. Connecticut, for example, not only has mobile crisis teams, but they also have specialized child and adolescent mobile crisis teams to serve the entire state. If we don't have these services in place when someone calls 988 and needs an in-person response, we're still dealing with law enforcement being dispatched when they aren't equipped or resourced to do so. And then lastly, crisis stabilization programs that treat people with respect and dignity are really pretty rare, though they're desperately needed as an alternative to emergency departments. So let's look at legislation. There are state laws being passed around the country to help finance the kind of 988 crisis response system that I talked about. And in the last year, which is the first year since the passage of the federal legislation, 4 states, Washington, Nevada, Colorado, and Virginia, have passed crisis response bills that have a fee on phone bills to help finance that system. There are other states like Oregon and Utah, Illinois, Indiana, which passed legislation that creates sort of the crisis response system, but didn't create a fee. Some of those states are looking at a fee for next year. Others like Utah actually passed funding through different ways in their state budget. We anticipate that a lot of states are going to scramble to implement 988 and maybe passing bills next year. I'll note that California had a bill that passed the assembly, but it didn't make it through this year. But it's a 2-year bill, so that'll get taken up again, but it's going to need a lot of support to move through. But the real value of having a piece of state legislation is not only to create an expectation around an infrastructure of crisis response like I described, but even a very small fee on a cell phone bill. And we're talking very small amounts. And I'll mention a Washington state. Theirs is 24 cents a month and goes up to 40 cents a month. And yet that generates millions of dollars for the state every year to help develop a crisis response infrastructure that is so badly needed. We want to make sure at NAMI National that we help support our state organizations in passing these laws. Fortunately, we're joined by a lot of partners at the national level. So I'd like to note that we are hosting, and I hope you save this date. Oops, I will go back here. And this is my last slide. We are hosting an event the week of November 15th through the 19th called Reimagine, a week of action to reimagine our national response to people in crisis. We hope you'll join us for that. It's going to be an exciting time, and we have so many partners who are joining us in hosting this, like the American Psychiatric Association, Mental Health America, Trevor Project, and many others. So if you are interested in this, there is a registration URL at the bottom of this slide, and we hope you'll join us. So with that, I will pause and thank you all for joining me today.
Wow, thank you so much, Angela. That was sort of a lot of information, and I think we have about 2 or 3 more minutes. There's just a couple of things I wanted to just really sort of highlight from hearing from you. That really NAMI's advocacy to increase the funding and advance policies is really making a difference. I mean, 100,000 emails to Congress. That's amazing, and how important advocacy is, and really elevating some of these issues to the policymakers. So, and there are many things. The 85% FMAP for crisis. That's really music to my ears, frankly. But it just, I think, again, Mayor Steinberg's comment that this is the time, right? And to really push for some of the issues that we really have been dealing with and really find solutions to them. And also excited for the 998, frankly. So really grateful for that. Unfortunately, we don't have any more time. But we are really grateful for folks who are listening. And we really are excited. Again, please join in and to get those alerts from NAMI National. The advocacy is really important. Thank you, everybody, for joining. Angela, again, so much information. Really are a force to reckon with all the work that you're doing. A reminder again, if you have any questions or follow-up, Angela's email is akimball@nami.org. Please remember to fill out your evaluations. If you have any questions about the conference, please feel to email nami.california@namicalifornia.org. Right? Have a good day, everybody, and we'll see you into the next session. Thanks again, Angela.
Thank you all.
Right. Bye-bye.